Hello everyone, welcome you all to our free session series of this year 2022 of Movement Maestro Academy. Today we have our resource person Dr. Amita Aggarwal ma'am, who is now working as associate professor at DY Patil College of Physiotherapy, Pune, Maharashtra. Welcome you ma'am. On this session, our discussion topic is peripheral nerve injury of upper limb. Without wasting our time, let's start the session. Over to you, ma'am.
Thank you so much. So now I'll be sharing my screen and we'll be having a session on peripheral nerve injury upper limb. Just give me a minute. Yes. Is the screen visible?
Yes, ma'am.
Okay. So we'll start with the peripheral nerve injury of upper limb. In this session, I'll be covering with the major objectives, which will be including an introduction of the audience to the peripheral nerve structure and the causes of the peripheral nerve injury. We'll discuss the classification of the peripheral nerve injury, and we'll discuss the peripheral nerve injury levels of the radial, median, and ulnar nerve. So before I begin, I would like to thank Movement Maestro Academy for providing me a chance to be a resource person here. And it's my I'm quite happy that I'm able to give my bit to the profession. So let's start. So the peripheral nervous system, it is consisting of the nerves and the ganglia outside the brain and the spinal cord. We all are aware that the nervous system is composed of two parts, central nervous system and the peripheral nervous system. In the central nervous system, we are having the brain and the spinal cord, and the peripheral nervous system will be consisting of the nerve and the ganglia. These nerves are including the 12 pair of cranial nerves and the 31 pair of spinal nerves. These spinal nerves will be connecting the central nervous system to the limbs and the organs. So it will act like a relay between the brain and the spinal cord and the rest of the body. So basically what is happening is that this peripheral nervous system, with the help of these peripheral nerves, is connecting these spinal nerves to the various muscles. Coming to the structure of peripheral nerve, these peripheral nerves, they arises from the spinal cord, and then they are referred to as the mixed nerve because they are having the sensory part, motor part, and that's why they are referred to as the mixed nerves. It even consists of a mass of axis cylinder with the neurulima tube. So here, if we see in this diagram, we can see that this is an outer covering, that is the epineurium. Inside this epineurium, there are bundles of these fasciculi. Each fasciculi in itself is having a covering of this perineurium. And this perineurium, inside this, we are having again so many nerve fibers together. And each of them is having a covering of endoneurium. And this consists of this axis cylinder, which may be myelinated and the non-myelinated. So they'll have the Schwann cells inside them for the myelination. So if we see here, there is each nerve fiber is enclosed within the collagen connective tissue known as the endoneurium, which in turn is connected with the later fasciculi covered by perineurium, and an outermost covering, which we'll see during the dissection, the major nerve, that is the epineurium. So this is a neurulima tube. This peripheral nerves, they emerge from the directly through the spinal nerves, and they also emerge during the plexus. So we have the cervical plexus, we have brachial plexus, lumbar plexus, sacral plexus. Causes of the peripheral nerve injury. Now, among the various causes of the peripheral nerve injury, commonest could be the direct injuries. In the direct injury, basically the traumatic injuries also, which includes the laceration. So in the cut injuries, so for most common example is a median nerve injury as a glass cut injury at the wrist level. So the patients will be experiencing the direct injury of the median nerve. Also, the reasons could be the laceration. If there is a laceration, there will be an involvement of the nerve with the gun stab wounds injury or with the gunshot injuries. So all such could be the causes of the direct injury. Then there could be a mechanical injury. It can happen following a compression injury, traction injury, and the friction injuries. So during a trauma, the patient might experience the compression injuries. So how these compression injuries will happen? They could be acute or they could be chronic. Acute injuries, when will they happen? If suppose a person he has been sitting on an arm, he has been sitting on a chair with the arm hanging on the chair. So in that case, there will be an acute compression of the nerve. For example, the radial nerve. We came across a Saturday nerve palsy or a crutch palsy, and the chronic compression could be if there has to be a passage of the nerve through a limited space. So if there is a passage of the nerve through that confined space, for example, again, a median nerve through the carpal tunnel. So that could be causing the entrapment neuropathies actually. So even there could be a fibrous septa entrapment. Now coming to the traction injuries. So sometimes when there is an mechanical trauma is there, the nerve may be pulled apart. So there could be a traction injury to the nerve. Then even there could be the certain infections. So for example, certain disease like leprosy, they are more prone to involve certain nerve structures. So like ulnar nerve is commonly involved as along with the common peroneal nerve in the leprosy. Then there could be a toxic agents which may have an involvement of the peripheral nerves, like in the radial nerve. Very interesting phenomena with respect to the peripheral nerve injury that is reported is a double crush. So this double crush syndrome, what happens in this? If a nerve, say a median nerve, if it is involved at one single level, there are quite a chances that the same nerve can get involved at another level too. So if the same nerve is affected at one level and there is a more susceptibility of that nerve to develop a compression at the other place, it is referred to as a double crush injury. So it pertains to increased susceptibility of a nerve to develop the compressive neuropathy when a proximal compressive lesion of the same nerve is found. So for example, if there is some nerve root compression of the nerve here, then along the course, if it has developed a compression proximally, the distal site compression could also be there. Moving to the second objective, that is classification of peripheral nerve injury. Two major classifications have been explained. One is a Seddon's classification and another one is a Sunderland classification. In Seddon's classification, we are dividing the nerve injury into three basic areas, that is neuropraxia, axonotmesis, and neurotmesis. These classifications are basically describing the severity of nerve injury. So if a person is having a neuropraxia, the chances of nerve affection is very less. So there is basically a physiological nerve conduction block that has happened. And there, as such, no anatomical changes are there. Only a physiological blocking is there. Such injuries, they will recover with time and mostly will take maximum of say 3 weeks. That's why after some nerve injury, a person should not immediately go for certain diagnostic tests because it could be neuropraxia and it will automatically recover with time. So minimum period of say 3 weeks is kept as a safe zone period. And after that, if the nerve is not recovering, then we can think of the axonotmesis and the neurotmesis. What happens in axonotmesis is there will be involvement of the axon, and there will be a problem with the axonal sheath, but the other outer coverings, they are not having any damage. In neurotmesis, there is a complete transaction of nerve. So if there is a complete transaction of the nerve, it is could be because of the knife injuries or a complete nerve has been injured there. Now, according to the Sunderland, it has been further subgraded into 1, 2, 3, 4, and 5, where in the diagram we can see that in this first diagram, this is neuropraxia, where there is only a conduction block, though the epiperi and the endoneurium all are intact here. While here you have the endoneurium is intact, but the axonal discontinuity has been seen, and this area is representing the Valerian degeneration, which will be happening to the distal stump area of the nerve. And in this, we can see that along with the axonal disruption, there is endoneurium involvement. Here, along with this, there is a perineurium involvement. And here, the complete nerve has been transected, so the nerve discontinuity has been present. When there is a nerve discontinuity, it has the worst prognosis and the chances of recovery are least. So the surgical options are looked upon. While in axonotomesis, though the recovery is seen, it has better prognosis than the neurotomesis. And it is common for the neuroma to form as one of the complications also in the complete nerve root transection. Now, to diagnose, we have to obtain certain information from our patient while taking his history and examining, so that it can assist us to diagnose which peripheral nerve has been injured. So while diagnosing, are certain things that has to be kept in mind while asking the history or taking examination is, we have to find that which nerve is involved. So to diagnose that which nerve is involved, we have to see. So if there is a glass cut injury, it is obvious that the median nerve could be involved. If there is a humerus fracture, if it is very proximal, then axillary nerve could be involved, say head level. But if it is around the shaft level of the humerus, then the radial nerve involvement can be there. Then at what level the nerve is affected? To determine where is the level exactly, we have to do the sensory testing, motor testing of the involved muscles which are supplied by that nerve, and also specific tests specific to those nerves are there. Third, we have to determine the cause. Many a times the cause is obvious, and sometimes it could be associated with certain diseases like leprosy we just discussed. Then type of nerve injury. Now, this type of nerve injury has to be determined to know how much is severe the nerve injury is. So it could be neuropraxia, axonotomesis, or neurotomesis. We also have to look for partial or a complete transection of the nerve. So the various diagnostic modalities such as NCV, EMG, they are playing their role to diagnose it. In case if it is an old injury, is the nerve recovering? So the Tinel sign will be checked for the patient. Coming to the nerves, like coming to the radial nerve now, we have to look for what are the levels at which this nerve can get affected. So this radial nerve is a continuation of the posterior cord of brachial plexus. So with respect to the brachial plexus, this nerve will be traversing a path in the upper limb. So firstly, it will be appearing in the axilla, but before it has entered into the radial groove within the axilla itself, it will be giving the branches to the long and the medial head of triceps. Now, after it has entered into the arm, it will traverse the path along the radial groove. So it will move along the posterior aspect of the humerus in the radial groove. And before it has crossed the elbow, it will supply within the radial groove only certain structures. Now it will be supplying even the lateral head of the triceps and also anconeus muscle. Triceps and anconeus, they are doing the elbow extension. But along with this, it has even supplied within the radial groove two other muscles, that is brachioradialis and extensor carpi radialis longus. These two are the forearm extensors, but they are supplied within the radial groove only before it has actually entered into the forearm. Now, within the forearm, after it has crossed the elbow, but before it has passed the supinator, this radial nerve will be supplying extensor carpi radialis brevis and supinator muscle also. And after it pierces the supinator muscle, it will supply extensor carpi ulnaris, extensor digitorum, the extensor digiti minimi, and the remaining extensors, that is the abductor pollicis longus, extensor pollicis longus, extensor pollicis brevis, and extensor indicis. Now, if we look, all these muscles are supplied by the radial nerve. So if we take a count, we'll have the in the axilla itself, the nerve is supplying to the muscles. So now coming to the level of radial nerve injury, it has been divided into the three levels. There could be a very high radial nerve palsy, which is referred to as the Saturday palsy or the Saturday palsy or the crutch palsy. What happens generally here is a neuropraxia condition. So the person may have certain crutch related injury, and like I have just discussed, sitting on the chair with the arm hanging. So the patient will be reporting with the paralysis of the triceps muscle. Even the triceps reflex will be absent. But here in this case, it is a very high radial nerve palsy. So if we look here along the course, I have mentioned along this side that if the level is very high, it will be almost at this level where any supply to the triceps will be compromised. More proximal is the injury to the upper limb, the worse is the prognosis. So at a very high level, there will be involvement of the triceps. If the involvement of the radial nerve injury is high radial nerve palsy, it can happen following a humerus fracture, especially the spiral pattern fractures occurring in the distal 1/3 of the humerus. So the radial nerve will get injured in the radial groove. Because it has injured in the radial groove and it has already supplied the triceps muscle, so the elbow extension will be there, the triceps function will be retained, but the patient will complain, will see the deformity, obvious deformity with the radial nerve, that is a wrist drop. Also, there will be an inability to extend the metacarpophalangeal joint because the extensor digitorum has also gone, and there will be experienced sensory loss along the distribution of the radial nerve. When there will be a low radial nerve palsy, it will happen following the elbow dislocations, elbow fractures, tight cast, and rheumatoid-like conditions, inflammatory conditions, where the nerve will be injured around the elbow. Here, the wrist drop will not be obvious, but the MCP joint extension will be seen. It will be seen lost. Why this happens? So if we see if there is a high level of injury, we can see here that all these muscles are gone. But when there is a low level of radial palsy, the muscles which are doing the wrist extension, even that is brachioradialis, extensor carpi radialis longus, which is a superficial extensors of the forearm, they are still there. I have highlighted the muscles extensors which are superficial. So we can see that these extensors are retained, and that's why the person will not complain, or we will not see the obvious wrist drop deformity when there is a low level of injury in the radial nerve. Coming to the next nerve, that is a median nerve. Now this median nerve is formed by joining the branches from the lateral and the medial cord of brachial plexus. The path that the median nerve takes is from the axilla, it will enter into the arm. Now in the arm, there is no overall muscle which is supplied because of the median nerve. But in the forearm, it will be supplying, after it has crossed the arm, it will be entering into the forearm, where in the proximal 1/3 area, it will be supplying the pronator teres, flexor carpi radialis, palmaris longus, flexor digitorum superficialis, flexor pollicis longus, the lateral half of the flexor digitorum profundus, and pronator quadratus. The rest two muscles which are left, that is flexor carpi ulnaris and the medial half of flexor digitorum profundus, will be supplied over by the ulnar nerve. So except these two flexors, all the other flexors of the forearm, whether superficial or deep, are supplied by the median nerve. Only the medial half of the flexor digitorum profundus, which is a deep flexor, forearm flexor, will be supplied by median nerve. In the forearm, in the distal 1/3, again it is supplying none, but in the hand, then it will be supplying the thenar muscles. So we are having the flexor pollicis brevis, abductor pollicis brevis, and opponens pollicis. We also have the lumbrical 1 and 2, that these two lumbricals are also supplied by the median nerve. Now, with respect to the median nerve, there could be the two level of injury. It could be a high level of median nerve palsy or a low level of median nerve palsy. High level of median nerve palsy will occur when the injury will be seen proximal to the elbow, and low if there is an injury in the distal 1/3 of the forearm next to the wrist level. So I have not discussed here about the entrapment neuropathy, but just overall with the traumatic lesions, how the injuries are happening. So at a high median nerve palsy, the patient will be complaining of an affection of the pinch. Why these all things are seen? Along with the pinch affection, there will be hand of benediction. What is this? So if we see here, this is a high level of injury. So almost all the muscles which are supplied by the median nerve are affected here. What has happened in the high level? Why the pinch has got affected? See, the patient has to do the pinching, so he'll need the muscles which will be doing the adduction here and see, if there is a pinch affection and there is a hand of benediction, so all the muscles of the thenar area are affected. Along with that, lumbrical 1 and 2 is affected. So this will be having an affection of the pinch of the patient. So with respect to the hand of benediction, we can see that when the person is asked to grasp a fist, there will be these two fingers will be left out. So they will not be able to flex. The reason being that if the person, it will happen with a high median nerve palsy. So why it has happened? If you see all the muscles which are given along the course of the supply, the patient is not able to flex he is not having an action of flexor digitorum profundus, the lateral half of both the fingers. Also, the flexor digitorum superficialis is gone. So these two fingers will remain in this position only. It is referred to as hand of benediction. Also, if a person has a low level of injury or a low median nerve palsy, the patient will not be having the thenar muscle function. So there will be a ape thumb. The patients will not be able to do the function of this abduction. So he'll not be able to touch the pen if it is kept here. So because the thenar muscles have been wasted. So what are the thenar muscles? Abductor pollicis brevis. The function will not be possible, and so the pen test will not be possible for the patient to complete. There will be loss of the thumb opposition also, and the patient will not be able to do the movements. Now coming to the next nerve, that is ulnar nerve. In the ulnar nerve, this nerve is arising from the medial cord of brachial plexus. What happens during the supply of this nerve? In the arm, again, it has no supply. In the forearm, in the proximal 1/3, the rest two muscles, the superficial and the deep flexor, which are left, are supplied here by the ulnar nerve. In the forearm, distal 1/3, there is again no supply. But in the hand, as it is referred to as musician's nerve, it is one of the major nerve which is supplying almost all the muscles of your hand. Total of 18 muscles it will supply. So overall, so in the hand, it will have a supply to the hypothenar muscles, that is flexor digiti minimi, abductor digiti minimi, and opponens digiti minimi. Also, the deep head of the flexor pollicis brevis and palmaris brevis, then adductor pollicis, palmar and dorsal interossei, 1, 2, 3, and 4 of both the interossei, and third and fourth lumbricals, they are supplied by the ulnar nerve. With respect to median nerve, it is also common to see the claw hand. Why? Because the lumbrical 1 and 2 are supplied by the median nerve. So if they are affected there in the median nerve injury, like a high median nerve palsy, the incomplete claw hand will be seen. In ulnar nerve also, the claw hand can be obvious along these two fingers. So the patient will not be able to have a flexion of the third and the fourth lumbricals, which is doing a function of this. So it is having a function of flexion here and extension here. And when there is a palsy, the patient will have the presentation of claw hand. What happens in the claw hand? Hyperextension at the MCP joint, and the interphalangeal joints will undergo the excessive, they'll go the complete flexion. So the claw hand will be visualized. So for the ulnar nerve, again, we have the two level of palsy. One is a high ulnar nerve palsy, that is injury occurring proximal to the elbow region. In this, we'll have the high ulnar paradox situation. We'll just explain. Then there will be low ulnar nerve palsy, where there will be injury in the distal 1/3 of the forearm. And the obvious signs seen are the Froment sign, diminishing grip strength, and the affection again of the pinch. So what is high ulnar paradox? Generally, it is said that if a patient is having a more proximal level of injury, the deformities will be seen more, because the more muscles are affected and deformities will be seen more obvious. But in the ulnar nerve injury, if there is a high level of ulnar nerve palsy, we can see that even the flexor digitorum profundus will get paralyzed. So if the flexor digitorum profundus will get paralyzed, the claw hand, which will anyhow be obvious, but because the flexor digitorum profundus has also got paralyzed, there won't be excessive flexion seen with the DIP joint. So it is a paradox. What happens normally, it is happening against that. So this is referred to as ulnar paradox, when the deformities at the proximal level should actually be seen more. Here it will be seen less, because at the high level, the claw hand will be seen less due to the paralysis involvement of the flexor digitorum profundus too. And there will be no flexion seen at the level of the DIP joint. For the low ulnar nerve palsy, the Froment sign is seen. So it is a book test. So if you ask anyone to hold out a book, so what they will do generally, when we are holding out a book, we need these muscles, these two muscles. So we need adductor pollicis here, and we need the first dorsal interossei muscle, and one is able to hold it very properly. But if there is a injury to the ulnar nerve, what will happen? The patient will not be able to hold the book, and there will be an obvious flexion seen at the thumb region. This will happen because he is using the median nerve supplied muscle, that is a flexor pollicis brevis, okay, and flexor pollicis longus. So he is using the median nerve supplied muscles instead of the ulnar nerve, because the ulnar nerve palsy is seen. So this is a Froment sign or a book test. There will be a diminished grip strength. Opposition will also not be possible because opponens digiti minima is also involved. Then something known as complete claw hand. There could be a combination of nerve injury. So if the ulnar nerve is affected along with the median nerve, then the complete claw hand will be seen because the lumbricals are involved. So it is very important for us to know that which is a nerve, what muscles it supplies, how the level of affection can vary, can show a variation in the presentation of complaints. And while doing your history and examination, how we can ask or we can check the various muscle tests, as like we were just discussing, to make sure that this is a level of affection of a nerve. These are certain of my references that I have used. Thank you so much. Thank you, sir.
Thank you so much, ma'am. Okay. Thank you so much, ma'am, for sharing your valuable knowledge with us. In this short period through this session, how everyone got lots of knowledge on peripheral nerve injury of upper extremities. Thank you everyone for joining this session, and thank you so much, ma'am, again for giving your precious time for this session. Thank you.